Hey, it's Andrew back again for another episode of Coding Matters, and I'm joined again by Bridget Kelly, who was formerly from the Medical Records Advisory Unit, but now you have a cooler name for your department. It is?
Yes, we do, Andrew. We have undergone a bit of a rebrand, and we're now the Health Information Governance Unit. Previously we were talking about medical records advice, and it's really, there's much more that we do as a central departmental unit. We're sort of the system leader for policy and governance in areas of clinical coding and health records. So done a bit of a pivot for our name to sort of reflect that.
It's a cooler name.
Yeah, I like it.
So we've wanted to talk a bit more about how the coded data is used. So thank you if you watch some of these videos and your documentation quality is improving, and that's leading to more accurate coding. Thank you very much for that. Keep it going. A bit of the feedback that we've had in discussion with other coders and clinicians is we talk a lot about funding on Coding Matters, and that's because I see that as a universal value proposition. But actually, it's used for so much more than just the income. And so we're going to have a short video where we talk about the other benefits of quality documentation and coding. So thanks for joining me for that, Bridget.
I'm happy to be back, Andrew. I'll talk about health data till I'm blue in the face.
Fantastic. Quick recap on activity-based funding, and before we move away from the money and talk about the other things, what are the key messages that you want to say about ABF?
The whole process of ABF is allocating funding from the Commonwealth Department of Health and Wellbeing, Department of Health and Ageing, to our jurisdictional health departments, as we're called, based on the activity that's actually occurring in our health services. And so in the admitted patient setting, this is where the process of clinical coding comes in. Clinical coders are reviewing all of the documentation that our wonderful clinicians make all across every single one of our hospitals in South Australia, and they're looking for diagnostic and interventional information that they can translate into coded data using some specific health classifications that we use every single day. And then that information is calculated into a final value that we call the diagnosis-related group, the DRG, and this has a level of complexity assigned to it, and it's used to actually calculate the overall dollar value that we will get for that episode of care. So the clinical documentation that you're typing into your electronic medical record or writing into your paper-based record in some sites is used all the way through this process and ends up informing the funding value that we'll get for that episode of care. So what's going in that record is very important for sustainable healthcare funding.
Yeah, potentially valuable, one might say.
Yes.
Let's move swiftly on from that one. But there are other benefits. Let's talk about the first one, service planning. And as a junior doctor, I really didn't appreciate this service planning business. I thought there's work to be done, we just get on and do it, and the money helps us do it. But it's a bit more complex than that. Can tell us about service planning? Yeah,
there's quite an intricate cycle of service planning, and it depends heavily on the relationships between the Central Department of Health and Wellbeing in Adelaide and all of the different local health networks, our LHNs. And so this process is called commissioning. So a basic flyover is local health networks are examining the services they're providing and trying to work out what they need to provide in future. Do they need to increase certain services? Do they need to set up new ones? And they'll make that proposal to the Central Department of Health and Wellbeing. They'll actually look at existing coded data to see the volume of activity, frequency of certain procedures is something that's often examined, and then they can make a bit of a position statement and a bit of, they can make a decision together about whether we're going to increase the volume of a service and, the resources we'll need to do that, or if there's something new that needs to be set up. We try and base it on as much of the existing data as possible, so we have a clear picture of how much services need to be planned, but also we have an idea of the costs of these services, so then we can fund it appropriately.
Okay, so if we kind of apply that to an example in haematology, my area, if we were seeing that a common type of lymphoma was increasing in frequency by 5% per year, we can give that data back to the department and say, we need more resources because we are seeing a continual rise, and this is the treatment, and this is how much it costs, and these are the complications that occur during treatment, and therefore, can you please fund and support a gradual increase in activity to meet the need?
Yeah, absolutely. That's a great example. And so then that increase could be reflected in something like getting additional oncology nursing, perhaps getting some more chemotherapy chairs, all that sort of thing, just to sort of increase the scope of existing services so we can, service the population depending on their needs.
Makes sense to me. And the second one is clinical research, and this is where we often talk about clinical audits. I had a problem with this when I was trying to do an audit on immune thrombocytopenia purpura, of course everyone knows that, ITP, which is a condition that drops your platelets due to autoimmune. And when I asked records for the last 5 years of ITP patients, about 30 to 40% of those that came through never had ITP. They had thrombocytopenia or low platelets from other reasons, but it had been not documented appropriately and therefore had not been accurately coded. And so if it had been accurately coded, I would have saved many hours of my time by not going through records that were irrelevant to my query.
Yeah, that's a fantastic example of, one of the reasons why we need our clinical documentation to function for research. Coded data is, quite often used to identify the appropriate patient cohort. And so like the example you gave, you're looking for patients with ITP. If it's not coded properly, you're not going to get that full picture. And so straight away, your research position, your study sample is compromised. So that's a fantastic example of why if you document properly or accurately with a little bit more detail, we can code that, and then you'll be able to see it if you need to refer back to data in future for any research or studies or tracking patient outcomes. It's there and it's reliable. We're guaranteed to have quality data.
Absolutely. And this is a bigger picture. It's the population and public health. And this bit's a bit beyond me because I'm kind of at the coalface. And sometimes as a coalface clinician, we don't have that bigger perspective, but your department very much does think about this.
Yes, this is where I get really excited. We're in South Australia. We're a health jurisdiction. We're positioned in Australia, but all of our health classification information originates with the World Health Organization, who obviously have a global scope, a global perspective.
That's the name, World Health.
Yeah. And so there's certain things, certain studies and certain demographic details, certain health outcomes that the World Health Organization is always tracking and always presenting publicly. Something that really fascinates me that I actually only learned about recently is something called social determinants of health. And so these are aspects of a patient which are not necessarily clinical. They could be something about their social situation, some demographic or economic situation that they're in, or certain cultural differences that patients have, which, no, they're not clinical, but we can say, yes, they are actually impacting their ability to access care or the delivery of their care. And so to use an example, this is a really great example of something happening right on a local level, a scenario of a patient fell off a retaining wall, fractured his tib and fib, so was taken to the RA to have surgery, was admitted into the orthopaedics ward. At the same time though, this patient found out that his brother had died quite suddenly. And so obviously, all of that sort of life planning, all of the funeral planning and things was happening. And it turned out that the poor patient, his brother's funeral was booked for the same day as his surgery. And so, he was quite stressed about it. So he had a conversation with the orthopaedics team and they actually made some arrangements so the patient could have their surgery beforehand and then go on leave so they could actually attend the funeral, still come back for some further, important post-op care to make sure they're recovering. But it was an example of not a clinical situation, a social scenario happening to this patient, which is actually influencing the way that the care is planned and delivered. So that's a sort of social determinant of health. And we do actually have codes for this in our classification. We call them Z codes because they all start with the letter Z. So the code we'd sign for that scenario is called the death or disappearance of a family member.
Wow, that's very specific.
Yes, I'm not sure how many disappearances we're actually capturing, but deaths of family members, that's something that can influence care quite commonly, I think.
Yeah, for sure. And I certainly see that, that even with free universal healthcare in Australia, there are still elements that influence access to care, geographical elements. And also we've had patients who have needed to look after children or pets even, and therefore that's influenced when they can and can't come for their treatment, which is challenging to work with, and they're obviously wanting to get the best quality treatment for their health, but they have these other obligations that are very important to them as well, and the relationships that are in their life. And another one that's also reasonably common are those that either are employed and therefore can take sick leave or extended leave without any kind of ramifications, but there are many people that run their own business who don't have a lot of savings and rely on that ongoing income, who then have to kind of negotiate how they can return to work whilst also having chemotherapy for their life-threatening cancer. That's a really hard thing. So I'm glad that there are codes and ways that we can measure that so that we can plan appropriately to support those patients.
Absolutely, and these codes don't necessarily have the same funding impact that, say, the actual cancer code necessitating the chemotherapy,
Sure.
but it's something that we can track. These are statistical measures,
Right.
and so it's really important for us to keep an eye on that as well. Another example on a more local level is our Australian Institute for Health and Welfare, the AIHW. They track all sorts of health outcomes. One that's really interesting is the National Centre for Monitoring Chronic Conditions. So they're looking at a lot of comorbidities which are very common across the patient cohort. So we're talking about, diabetes, hypertension, osteoarthritis and osteoporosis. And so they rely on what we call supplementary codes, U codes. They start with the letter U. And again, these aren't necessarily impacting funding unless they're actually being actively treated in the episode of care. But even if they're just documented in an episode, we can assign one of these supplementary codes, and it's just it's adding to that statistical measurement of how many patients, are coming into hospital who have background hypertension or osteoarthritis or certain disabilities and other degenerative conditions like dementia or multiple sclerosis. These are all U codes that we can look through. Often we'll find it in like a patient's history that a clinician will take. We can actually review that, and we'll pick up all of these U codes and add them into our coding string, usually at the end. We add all of our U codes in, and they can actually be captured and measured by AIHW.
Yeah, and I suppose hopefully, and I've seen this in Victoria directly, is that then government agencies are accessing that data and able to make policy and program decisions based on that data to better serve our population, improve not just their health but other elements of the way that we live as well.
Yeah, absolutely. Like, we collect all of this data and we don't just sort of put it in a repository or make it into a report and then just leave it. It's all used for various purposes, and like policy, that really high level strategic planning, that's often where these reports come in really useful for governments and government departments.
It's from your documentation. Thank
It
you.
all matters.
Yeah. So the last one is on classification development, and certainly I went to a conference recently where we were talking about how do we make sure that our codes are keeping pace with the newer contemporary ways that we're treating conditions. Some great examples were from cardiology, where they're now using one-use devices as part of their angiogram and other interventions, but not all of them are being captured. But it's certainly costing more from a resource perspective, because some of those are costing $1,500 per procedure. That is a cost that's currently just being added on without being reimbursed. So how do we make sure that we are making sure the classification is keeping up with what we're doing on a day-to-day basis?
Well, there is a very rigorous and quite well-planned process that we call classification development. So ICD-10-AM, that's the classification of diseases, and ACCI, which is our classification of healthcare interventions, so procedures, surgeries and things. These undergo a development cycle that takes 3 years. During this process, the Independent Health and Aged Care Pricing Authority, who are a national corporate Commonwealth entity, they manage these classifications, and they'll actually review them, and they set up a project plan, and they'll look through areas of the classification and correspondence they've received from the states, the healthcare jurisdictions as we call them, and they'll make proposals about what should be added, should something be changed, and technological developments in medicine and surgeries is a really great example of new codes and new things that we add into the classification during this process with the IHACPA. It's very sort of strictly controlled, because we need to make sure that our classification is stable as well. So we don't just say, all right, we'll just throw in some codes for, this new technology. There's quite an intensive research process that goes into this, and something that we try to gather a lot of is any data that we have of similar conditions or interventions which are appearing in these new spheres, and also the costs of this data, because remember that the classification is used for activity-based funding, so they're trying to work out how much these things cost. So what DRG do we need to make sure these new codes would group to so they're appropriately funded? Leadless pacemakers are a really fascinating new technology where that pacemaker generator is inserted into the patient, but they no longer need all of the extensive leads, which are often a bit difficult to insert and quite expensive as well. So now we have leadless pacemakers. So this was a new code that was introduced in our last classification implementation, which was this year on the 1st of July. So now coders, if a patient has been documented as having a leadless pacemaker inserted, there's a specific code for that. And it's costed and measured appropriately, so we know that'll be funded.
Great,
Yeah.
That's really good.
Yeah. Another thing that we update in our 3-yearly classification development is outdated clinical concepts will be revised. And so this is where the Health and Aged Care Pricing Authority will be looking at recent developments, maybe some consensuses, international developments in care delivery or understanding of diagnoses. A really great example is the clinical changes to the understanding of sepsis. The Sepsis 3 Convention, which I believe took place in 2016, sort of reviewed the understanding of sepsis in patients because we knew that the existing definitions weren't actually reflecting what was happening in patient care. And so there were some big changes. The idea of a patient having severe sepsis was sort of determined to be a bit redundant. And also the idea of sepsis has sort of been revised to now include in any sepsis diagnosis that there is significant risk to organ function. So organ dysfunction is sort of inherent in a sepsis diagnosis now. And so we had to change our clinical codes because the way we assigned our sepsis codes was a patient could have sepsis, and if a patient had sepsis and documented organ dysfunction, it was severe sepsis. So that's now redundant. So we've actually made our severe sepsis code invalid for application. And so now we've got an updated classification to increase consistency with that new medical understanding.
Fantastic.
Yeah, and that's pretty cool. That was a global change. So that's something that, you know, health jurisdictions all over the world would have to update their coding as well. It's pretty fascinating.
That's good. So there's often like an element that's the ICD-10 or whenever 11 comes out, which is the whole world, and then there'll be some things that we're adapting for the Australian context because it's the 10 a.m.
Yeah, absolutely. And we have a really high quality modification of ICD-10. So the Australian modification that we have, it's actually applied in other countries as well. So Saudi Arabia, Ireland also use it, New Zealand use it. I think there are a couple of other countries in the Middle East. So our classification is such high quality that certain countries are saying, we're not going to try and develop our own. We don't want to reinvent the wheel. We'll take this one. It's fit for purpose.
Oh, wow.
So that's pretty cool.
I didn't realise there were that many countries that were using it.
Yeah, there's quite a few.
Thanks for joining us in other countries.
If you're signing in from Saudi Arabia or Ireland. There are also sometimes some changes in sort of social or cultural understandings of conditions or sort of personal situations, which also necessitate an update to the classification. So a really great example of this is the concept of gender incongruence, so gender diversity in a patient. Previously, the codes that were the closest codes we had to capturing somebody who experienced sort of a different experience of gender to their biological sex, there were a lot of really outdated and stigmatizing and, you know, quite offensive terms like transvestism. That's not actually capturing what's happening with a patient.
Yeah, I definitely have never used that term.
Yeah, thank goodness.
Yeah,
and so now it's been updated and we use the term gender incongruence, which is sort of the kind of standard terminology, just explaining that this patient, they feel their gender is incongruent with their sex assigned at birth.
Very neutral,
absolutely,
non-judgmental language.
Yeah. So that's an example of how, you know, society changes codes a little bit as well. And then finally, you know, sometimes we'll have a condition or a new intervention or something which sort of pops up on the radar quite quickly. And the World Health Organization and the Health and Aged Care Pricing Authority in Australia have to move very quickly and implement what we call emergency use codes.
Like COVID-19.
Yes.
It's been thrust upon us, and then a whole bunch of medications and the way that we practice has quickly changed within 12 months.
Absolutely. So the World Health Organization actually activated some emergency use codes for COVID-19, and Australia adopted those for our use, and we've actually updated those a few times. Originally, when we had COVID-19 codes implemented, it was truly just, do you have symptomatic COVID? Do you have asymptomatic COVID? Were you tested for COVID? And it was ruled out. They were the only codes we have. Now in our new classification, we've built out those codes and we're also capturing symptoms of, we've got one of a post-COVID-19 condition. So that's long COVID. We can capture and identify those episodes because we know that that's a very hot topic in terms of clinical research and determining the ongoing costs and funding that's required to treat that. So we do have the ability to pivot the classification if we need to. Within that 3-year cycle, we can actually act quickly and implement something, very, very rapidly if we need to. We don't sort of do it all the time, but and we'll wait till the next pandemic before we put some more in.
Good to know. So I think it comes down to, great to know that those big pictures. How do we make sure that we can contribute to the bigger picture at the front line as clinicians? Being explicit, being specific, and using diagnostic terminology. Being relational means this thing happened for this reason, linking actions with diagnoses. And being really clear about things that have happened and often the reasons why those things have happened.
Absolutely. I don't want any clinician watching this video to sort of feel overwhelmed or worried about, oh my goodness, my documentation is not sufficient for the World Health Organization's needs or anything. You don't have to reinvent the wheel. You don't have to be a novelist. We don't need war and peace in clinical documentation. We need you to document what matters. And so luckily there's a great suite of Coding Matters videos here on this YouTube channel that you can keep watching if you're working in a particular clinical specialty and you'd like to learn a bit more about, how can I sharpen up my documentation skills? And there's even a few examples of sort of the end result, the improvement that we see in the health data world as it flows through. So you're not on your own, and remember, if you ever have any questions, you can always approach your friendly clinical coding team in your health services. Something that I'm really passionate about, and you are as well, Andrew, is actually building our relationships between clinical coders and our clinicians.
Absolutely.
Yeah, I think, we have a lot to learn from each other. Our clinicians can learn a lot from us about sort of the health data uses and the funding that we derive from health data based on clinical documentation. We have a lot to learn in terms of nobody knows medical science better than our clinicians. Nobody knows what it's like on the ward better than a clinician. So that's the relationship we want to build and the benefits we can get from each other.
And I think that idea of seeing, rather than that we're teams in isolation, we're actually one big team, that we, as a clinician, I need the administrative, financial, coding support in the background to continue doing what I'm doing for my patients. And you guys need us as clinicians to be aware and mindful of the way that we are documenting to make your job easier, which ultimately all of it is benefiting the patient and their care.
Absolutely. A really great analogy I heard somebody explain to me the other day was it's like a Formula One team. Now you've got all these different people performing different roles and they're all trying to make the car work and the driver get out of the pits. So you might have mechanics changing tyres, you'll have engineers developing technology to make, a car more aerodynamic. Everyone's working together for that common goal. We just have very different roles, and we don't expect, the mechanics to know all of the ins and outs of engineering and aerodynamics, but we need to sort of have an understanding of the part we all play and, a respect for all the work that we're doing, because I think we all want the same outcome, which is a sustainable and safe and high quality public health system. We're very lucky in Australia to have such a, this fantastic public health system. Admittedly, it's been under a lot of strain recently.
Yeah, could be better, but it is overall pretty good.
Yeah, so we want to keep it that way, and we want to make it, sort of quality assured for the future as well.
Okay, well, thanks for joining us and sharing your insights on the big picture.
Happy to help.
Cool. See you again soon.
See ya.